Hello class, we're doing the next chapter, chapter 9 on joints. It starts on page 139 in your textbook. This is a pretty short chapter. The first thing we're going to talk about is how joints are classified. They're classified according to how movable they are and the material that is used to bind them together. So the different classifications are fixed, semi-movable, and freely movable. Fixed are bound by fibers. These are called fibrous joints. So that is an example of a suture joint that was used in the adult skull that we talked about, and that keeps the bones in the skull knitted together. The next one is a semi-movable joint. Okay, this contains cartilage, and if you look in the picture on page 139, it shows a picture of the symphysis pubis, or the pelvis. You can see that small piece of cartilage that is connecting the joint together. So cartilage, again, is a type of connective tissue. And then you have your freely movable joint. That's on page 140. That is your synovial joint. Contains a fluid-filled joint capsule. These are, again, synovial joints. These are the most numerous, or the ones we have the most of, and the most versatile. Okay, they allow us to move freely.
To the channel. It would really mean a lot to me if you did. Alright guys, without any further ado, let's get right into the video. Joints. In case someone says your shoulder articulation is dislocated, don't panic. Articulation is more commonly referred to as joints. Joints are skeletal structures which function to join or articulate two different or more bones in the body. Additionally, they are important for mobility. There are approximately 400 joints in the human body. No worries though, since we only need to focus on a few, which are some of the more common ones, in terms of function and of course vulnerability. Since we have a lot of joints, it's only proper that we classify them according to either structure or their function. When we refer to the structure, the focus lies on the type of tissue that seals the connection. The tissue can be synovial fluid, a fibrous tissue, or the most common, cartilage. There are instances when the tissues involved are a combination of the three. As for the function, joints are classified according to the level of movement they allow the bones to make, as well as the number of bones needed to make the movement. Note that these two, structure and function, are closely related to each other. So, let's go over these. Types of joints according to function. Structural joints can be immovable, slightly movable, and lastly, freely movable. Immovable joints like the skull are connected by fibrous tissues. Slightly movable joints, like the ones found in the spinal column, are held together by cartilage, which are softer than fibrous tissues. The last one, the freely movable, are connected by the synovial fluid. An example of a freely movable joint is the shoulder joint or the knee joint. Types of joints according to structure. As mentioned, there are three types of joints according to structure, or the kind of tissue that holds them together. These are fibrous. These are joints which surfaces are sealed by fibrous tissues. Given that they are fibrous, the connective tissues are hard, and movements allowed for the bones become very limited, making the bones close to immovable. 2. Cartilaginous are the joints that connect via the softer cartilaginous tissue. Cartilaginous joints are interesting in such a way that some joints, called synchondrosis, turn into a full-fledged bone when adulthood comes. Symphysis is another type of a cartilaginous joint. The joints in this type are held together by fibrocartilages. And 3. Synovial. These joints allow the most movement for bones. There is a synovial membrane at the bone which produces synovial fluid, which will act as the lubricant to allow free movement. Amongst these three structural types of joints, the synovial articulation is further classified into several kinds. Gliding joints, such as those found on your fingers. These joints, as you can demonstrate, can make your fingers move in all directions. The fingers can only clench. Hinge joints, like those found in the elbows and knees, act like hinges of doors. These movements are also limited. It's either you bend or you straighten. Pivot joints. From the word itself, these joints allow you to pivot or swivel to a certain direction. Think of your head, which can swivel to the left or the right, or up and down, but only to a certain degree. Condylar joints. These are the joints that allow versatility in motion. With condylar joints, you can perform bending, stretching, abduction, adduction, and circumflexion. The perfect examples of these joints are your hands. Ball and socket joints. The only ball and socket joints we have in our body is the hip and the shoulder joints. These kind of synovial joints has a rounded bone that fits into a concave bone indentation. Saddle joint. These joints are like condylar joints, but they allow more movement. The only saddle joint in our body is found in the thumbs. As you can imagine, thumbs need to be more movable because they are used for fine motor skills. Alright guys, I really hope you liked that video. I hope you learned a ton. Make sure you stay tuned because in the
Okay, so she did discuss the different types of synovial joints in the video. The pivot joint, again, is one that rotates, and that is in your vertebrae. That's where you can find that, so that rotates from side to side. Hinge joints, that allows back and forth movement, like the hinge of a door. So that would be, an example would be in your elbow. The gliding joints allows flat bones to slide over each other, and this is all on page 41. Okay, so that is an example that is in your wrist. The ball and socket joint, this is in your shoulder and your hip. These are the joints that allow the widest range of motion. So you can rotate your shoulder circularly, you can rotate your hips, so that has the widest amount of rotation. Saddle joints, okay, that is an example of what's in your wrist. And what these do is Sorry, I got interrupted for 1 second. So these saddle joints, what they do is they allow movement of the bone from side to side and also back and forth. An example of that is found in your wrist. And then your condyloid joint, this allows flexion and extension and also movement from side to side. The movement of synovial joints continues. It depends on the shape of the joints, and also depends on the muscles, the tendons, and the ligaments that are nearby. So remember, tendons connect muscle to bone, and ligaments connect bone to bone. Now we're moving on to page 142. This is movement of synovial joints. So synovial joints allow for movement depending on the joint type. So there's some terms that are associated with this type of movement. The first one is flexion. On page 142. It involves the bending of a joint to decrease the angle. Extension increases the angle, and then hyperextension is the extreme extension of the joint. So if you've ever heard of hyperextending the joint and having an injury, that's what it's from. You have your dorsiflexion and your plantarflexion. So your dorsiflexion is, an example is raising your toes upward towards your head. Plantarflexion is pointing your toes downward. I remember plantarflexion, like if you're planting a seed, you're gonna press into the earth to have the seed planted, so you plantar flexion. Abduction and adduction. So abduction, you're moving the joint, the hip joint for this example, away from the center of the body. So this is the center of the body, you're moving the joint away. You're abducting, you're taking it away. Adduction, you're adding it. So you're starting from the furthest point, you're further a point away, and you're adding it to the center of the body. Circumduction. Circumduction is when you're the distal end, okay, the end furthest from the joint of the arm or the leg moves in a circle. Okay, so circum, you can think of that word, circum, moves in a circle. Internal and external rotation. Okay, this is the rotating of a joint. Internal rotation, you're rotating it internally, so towards the inside. So you can see that knee is going towards the inside. External, the knee is going towards the outside. And then you have supination and pronation. Supination is the movement of when the palm turns upward, and pronation is when the palm turns downward. Okay, so supination is upwards, pronation is downwards. And all of this can be found on page 143.
Welcome to Anatomical Yoga. We'll start at the top of our mats in anatomic position, gently elevate and retract your scapula with ever so slight cervical circumduction. Now, flex your dominant hip and knee while an externally rotated contralateral hip and flex knee allow you to rest your foot on your thigh. Next, we'll move on to my favorite, the downward Vesalius. If none of that made sense, then keep watching this video, because today we're talking about movement terms. What's up, y'all? My name is Pat Kelly. I got another anatomy lesson for you. Today, we're talking movement terms. These are all the motions as they apply to the body. So we're gonna go over what those movements are, what joints they apply to, and give you a few memory devices so hopefully you can remember them easier. I made this video to accompany my anatomical regions and directional terms videos. So if you haven't seen those, I'd recommend clicking that link right there to get a little bit of background. So here's the big picture. We have multiple joints that all move in incredibly unique ways, so simple terms like up, down, and sideways don't apply here. We need unique terms to describe unique motions. And when we're talking about anatomical motion, we reference an imaginary body in something called the anatomic position. That's standing upright with feet forward, arms by your side with palms forward, and head neutral looking forward. I've said it before and I'll say it again, always refer to the anatomic position whenever you're talking about direction or motion. This is forever and always your starting point in anatomy. Why? Well, it's tempting to say something like move the patient's leg up to refer to hip flexion when someone is in the anatomic position, but that's a completely different motion than if they're lying on their side. So in order to standardize language, we always refer to the anatomic position. The second thing to keep in mind is that there are different planes of motion and different axes of motion with which these limbs and joints move around. Obviously, your body exists and moves in 3 dimensions. So while some motions seem like they happen in a very straightforward, linear way, most day-to-day motions are a combination of those. Let's start with abduction, which is movement of a joint away from the midline of the body, and adduction, movement towards the midline of the body. Specifically, this midline on the sagittal plane. Now, clearly these words sound very similar, and some folks will painstakingly spell it out abduction to make it super clear. But the difference is actually way easier to remember. I picture an alien abduction taking my arm away from me, whereas with adduction, I'm adding to the size of my body. You'll see these motions all the time with shoulders and hips, but you can also apply them to fingers and wrists. In those cases, abduction doesn't necessarily mean going away from the body's midline, but from the midline of the hand. So really, finger abduction is the same thing as spreading your fingers, while adduction is closing them. One little note though, some clinicians will call this motion wrist abduction or adduction, but some will say radial deviation, meaning the hand is moving towards the radius, or ulnar deviation towards the ulna. They're the exact same thing, but since the hand and wrist are so often not in anatomic position, they're easier to remember this way. Next up is bending and straightening. More technically, flexion, which is a decrease in the angle between two joints, and extension, an increase in that angle. It's pretty intuitive for joints like the knee, elbow, or even spine, but some joints are a little trickier. Like this is shoulder flexion, and to me, it just looks like my arm is going away from my body. So I had to come up with a separate way to remember flexion versus extension. I remember that flexion is like the fetal position, which clearly both start with F. Check it out. The hips and knees are in flexion, the shoulders, elbows, and wrist are in flexion, and the neck and all parts of the spine are in flexion. That's right, flexion and fetal, the two best F words for any memory device. Extension is the opposite. You're increasing the angle between two joints, which usually results in straightening the limb or extending it past that frontal plane midline. But be careful because flexion and flexing are two very different things. When we say flex a muscle, what we're actually saying is to put tension on it, to contract it. And yeah, when you're flexing your bicep, you're also doing elbow flexion, but you can flex your quadriceps while you're extending your knee. Got it? Rad. Moving on. Next up is medial and lateral rotation, sometimes called internal and external rotation. And just like picturing rotation from physics, we first need to figure out what our axis is. So for both the shoulder and the hip joints, our axis is going to be an imaginary line running through the long bone of those joints. You can do this with me. If you stand up and lock out your elbow and rotate your shoulder so that your thumb starts pointing towards your midline, you've medially or internally rotated the shoulder. Now on the flip side, the thumb is heading back out, so we're doing lateral or external rotation. Same thing with the hip joint. If you stand up and lock out your knee, when the foot goes towards the midline, that's medial rotation. If it goes out, lateral rotation. But remember, movement terms use the anatomic position as a reference. So if we're in standing, we can get away with using our hands and feet as little guides, but that might completely disappear if we have our person change position. Like, imagine for whatever reason you wanted to assess a patient's internal shoulder rotation in a seated position. It's going to be really difficult to work with a straight arm, so you have your patient bend their elbow. Now, in this case, internal and external rotation still make intuitive sense. My arm is going towards the midline or away from the midline, which agrees with the long axis rotation we defined earlier. That's awesome. Unfortunately, that doesn't translate to the hip joint. Right here, I'm actually doing medial hip rotation. The long axis of the femur is rotating towards the midline, but my lower leg is all out to the side. Vice versa when I do lateral rotation or when you test this in the supine position. Okay, lesson learned, if you look at the long axis of the bone in anatomic position, you'll never trip up. So those are our major multi-joint movements, but there are some exceptions, and from here on out, it gets pretty specific. Like the radius has the ability to flip around the ulna due to a cool little pivot joint between the radius and ulna that's totally separate from shoulder rotation. This is called supination and pronation. Supination everyone remembers because you flip your hand up like you're asking for soup. It gets dumber. On the other hand, I remember pronation because it's like a bunch of pro national football players all putting their hands in on the pile. Also, can I get credit for putting literally the other hand in? But it gets even weirder and more specificer. Like the ankle joint, specifically between the talus and the lower leg, do something called dorsiflexion and plantar flexion. I remember these because when you point your toes down, you're planting your toes on the ground. Then when you point them back towards you, you're pointing them towards your dorsal aspect, your back, where we'd keep our dorsal fin. But the ankle can still wiggle a little more. That same talocrural joint rotates around the long axis of the metacarpals to do inversion and eversion. Easy way to remember those, if you invert your feet, your body will trip over and your body will end up inverted too. But you could forever comfortably stand in eversion. We're getting to the end, but lastly, we need to look at the scapula. They can elevate or depress, protract or retract, all of which are pretty intuitive to remember. Finally, we have circumduction, which is this big silly looking circular motion that happens at a few joints, including the neck, shoulders, and hips. Now, those are all the major motions, but there are a couple things to keep in mind. As a clinician, you're probably going to care about these movement terms because they're going to help you document things like range of motion and functional movement. Usually we care about 3 types of movement. Active motion, which means the patient is moving the joint through their own effort. Passive motion, which means the motion is being done to them either by your hands or by a machine, and resisted motion, which is self-explanatory. Some kind of resistance is being placed on that motion. And those are important distinctions to make because that might help you with your assessment. For instance, if somebody had painful active shoulder flexion, but they were fine on passive shoulder flexion, you can use that information. Now, all anatomy students are going to need to know these movement terms, but if you're more interested in movement itself, I'm going to recommend this playlist up here. It's my musculoskeletal, biomechanics, and kinesiology playlist. Specifically, I'm going to recommend this video about origins and insertions. I think it'll be really helpful.
Okay, that's it for chapter 9, and we will go over it a little more detail briefly in class. Thank you. Have a good rest of the day.